Hello everyone, good evening, uh, good afternoon, and good morning, wherever you have joined us from. Hi, I'm Priyanshu from Alcon Faco Development, and I'm your host for today's evening. Let me take this opportunity to welcome you all with this yet another exciting PDTV session, new challenges of new era, post-refractive cases. And before I start, I would like to welcome our today's faculty, Dr. Sagar Bhargava. Dr. Sagar has more than 20 years of experience in the field of ophthalmology. Currently, he's attached with Netralayam, the super specialty eye care from Kolkata, as director and senior consultant. Previously, he was attached as Deputy Director, Shankar Netralaya, Kolkata, where he was served as Senior Consultant, Glaucoma, Cataract and Refractive Surgery Department. And Master degree from Government Medical College, Aurangabad, Dr. Bhargava joined Fellowship in General Ophthalmology at Shankar Netralaya, Chennai. In the year 2008, after successfully completing his exam, he also acquired a degree of FRCS. Dr. Bhargava won many awards. Prominent among them are Dr. Pandit Palitkar Memorial Prize for standing first in first MBBS university exam in 1995. He was also awarded Dr. R.L. Balachandra Memorial Prize for securing highest marks in MS university exam in 2003. He started LASIK Center of Shankar Netralaya in Kolkata in 2011, and he was the first to use femtosecond LASIK, that is bloodless LASIK in East Force in annual meet of American Society of Cataract and Refractive Surgery. And beside, he's a prolific surgeon and a very good human being. Welcome, sir. And before handing over the session to sir, I would like to, your audio will be muted throughout the session and your video will be off. So we would like to encourage you to post your queries in the Q&A box so that our speaker can address those queries at the end of. So without further delay, the session is all yours.
Good evening, everybody. Thank you, Priyanshu, for that nice introduction. And this is a very vast topic, and I hope to do justice in the prescribed time that I have with me. And to start with, we now have almost 40 million cases who have undergone refractive surgery till date, and add to this about 3 million per year. So we can obviously see that in the coming years, we will have huge patient load who will have a refractive surgery, who will come to you for cataract. So whether you like it or not, you need to be equipped. You need to equip yourself to handle this situation. So why is it challenging to operate a post-refractive surgery cataract? So there are many challenges. The first and foremost is what to measure in the cornea. Second is what IOL formula should I use? What then comes with the plethora of IOLs that are available to us now, right from monofocal, multifocal, trifocal, bifocal, EDOF, which lens you should use and when. And then on the top of it, if you have an RK patient, it has so many intra-op challenges that you need to address. So my talk will be essentially a practical oriented talk, which will deal with different aspects which you will face when you see a patient who comes for a cataract surgery, right from history till post-op assessments. Let's go one by one. So in history, what are you going to ask? Basically, you would want to know what is the type of procedure patient has undergone, because that will determine the calculation mode. Then the type of correction that the patient has undergone, whether it's a myopic or a hyperopic, because the corneal curvature will obviously different in the two types of refractive procedures, and that will change the spherical aberration pattern of the cornea. Then it's very important to find out whether it's a unilateral or bilateral procedure. There are times when the patient would just do it for a single eye, and he or she might forget that which eye the patient has undergone this procedure. So it's a good idea to look at the records to see which eye, because I recently had a patient who had actually unilateral LASIK. The other eye was untouched, and we really had to dig out the data to actually find out which eye had the procedure and which eye didn't. That there was not too much changes in the cornea because the correction was very small. Then you also would want to see the pre-refractive refraction, the pre-refractive surgery refraction and the vision. The obvious thing that you look for is whether the patient was amblyopic or not, because that will have a impact on the post-op vision recovery of the patient. Once the patient has undergone the refractive surgery, look at the papers to find out what was the best corrective visual acuity. Because if the visual acuity was very good in the patient, that means he had a good quality of vision and he had a good correction. Second thing, it gives us an idea as to what was the refractive change. So for example, patient was having a -9 pre-op and patient becomes now -1. So your refractive change at the spectacle plane becomes 8. So that is an important input which we will see how to use it. Then whether there is any history of contact lens, because then we will have to discontinue the lens before measurements. And most importantly in today's era is what is the patient's expectation and personality, because we will see why that is also important in deciding which lens we need to implant. So clinical examination, apart like in LASIK or RK, apart from other things, you need to do a dry eye evaluation, including history, Shermer's, and the routine dry eye assessment that we do. And if you find out that there is a dry eye, better to defer any tests further, treat the patient, and then retest the patient. Because as such, you are having a cornea which you need accurate measurement, and if there is a dry eye, your measurements go for a toss. So it's good idea to treat them. In an RK patient, you would want to note what are the number of incisions that the patient has undergone. And beyond that, it is all a standard evaluation. Now, the next thing is what investigations you will do. So essentially, I would put it this way, that any patient who has undergone refractive surgery, it's important to get a topography done. Possibly, I would say even mandatory, because you will never know what is happening in the cornea. Of course, biometry, and certain times you need to do special investigations. We'll come to that in a minute. So when we do talk about role of topography, you basically look at these points, which I'll show you in the subsequent slides. What we routinely use is Pentacam. I think that's something which is easily available everywhere. So when you order for a Pentacam, this is the first map that you will get for people who are not used to seeing Pentacam. So you get a sagittal curvature map, and you get a elevation maps. So essentially what you see is a blue zone, which is a zone of flattening. So this is where the refractive surgery or a myopic LASIK or a PRK was done, and this zone has become now flat. So this is what you need to first look at, and then you need to look at the anterior elevation values and to see whether they are symmetrical or not. So just look at this picture now. Now you can see the same blue zone has kind of shifted upwards. So what is this? This is nothing but a decentered ablation. A decentered ablation meaning the ablation is slightly decentered, either up or down. So this is what happens. So how do you detect it? Is basically you see a dioptric difference between the superior and inferior K measurement. So here the difference is almost 5 diopters within the 3 millimeter zone. So this is definitely a decentered ablation, and you can see that the elevation pattern is asymmetrical. So you have elevation here in this zone, but there is no elevation in the top. So this is basically a decentered ablation. Compare this with this ablation pattern, which is a very smooth pattern, and there is no difference in the superior and inferior dioptric values, and you can see the elevation map quite symmetrical. So this is something that you need to keep in mind. Now, why decentered ablation is important? Because it gives rise to increase in higher order abrasion or coma abrasion, and in these patients typically you may land up with an inaccurate IOL power calculation, and also this may indicate to you that patient may have a poor visual quality after the cataract surgery. So is there any way you can predict a refractive outcome in these patients by looking at certain parameters? So one of the map that helps us in detecting this is EKR distribution map. So EKR, what is EKR? EKR is equivalent K reading, which Pentacam gives you, and it gives you in the form of holiday EKR report. And what you see, a graph here, is basically in a 4.5 millimeter zone, the distribution of different points representing the EKR values in that 4.5 millimeter zone. So if you have a zone, if you have this graph with a narrow base, that means the range of EKR powers is very narrow with a one or two peaks. This is something which is desirable, and that's where you will get a predictable outcome, a single peak with a narrow base. Now compare this with these two graphs. So here you see a broad base indicating that the K values are right from 29 diopters to 39 diopters. So there is a wide zone, the wide variation in the values. And if you have multiple peaks, that means you have a cornea which has multiple points which are quite steep. So here you are going to get a surprise. So this graph kind of gives you a first idea whether you are going to have a predictable outcome or not. Next, you need to look at the aberration pattern. So because we know that post refractive surgery there is going to be some induction of higher some increase in higher order aberration and spherical aberration. So we need to look at that because these aberrations are going to deteriorate the quality of vision. So higher their value, poor is the quality of vision. As we can see from the figure here of chroma and trefoil, you can see how the vision deteriorates as these values increase. So how do we determine this? Luckily, with the newer machines, you get this something called as a pre-cataract display, and it gives you these two values. One is called as total higher order aberration at 4 millimeter diameter, and as you can see, it is showing about 0.18. And below that, you get corneal Z40, which is basically spherical aberration at 6 millimeter zone. So we have to remember that any total corneal higher order aberration more than 0.3 would indicate that the patient has some degree of irregularity, and you have to be wary about these kind of patients as they may show some unwanted visual symptoms. So coming to the same patient we saw in the first slides where there was a decenter ablation, you can see how the corneal higher order ablation is high in these patients, almost 0.6, much beyond 0.4. And compare this to this patient who has a centered ablation and the corneal higher ablation is just 0.199, which is quite less. So this patient will have definitely a much better vision quality compared to the previous patient. Now, the another question comes is which lens whether should we put in a patient with a myopic LASIK who has undergone myopic LASIK or a hyperopic LASIK. So we have these aspheric lenses and we have non-aspheric lenses and we have zero spheric lenses or zero aberration lenses. So in myopic LASIK, what happens is there is a corneal flattening. So what happens to the cornea is it develops positive spherical aberration. So if you have positive spherical aberration, and if you put a non-spheric lens, so you are going to increase the spherical aberration. If there is an increase in spherical aberration, then you will get halos and other unwanted symptoms. So best in a patient with myopic LASIK is to put a negative aspheric lens which will counteract the positive spherical aberration of the cornea. Though the spherical aberration can go up to 0.9, 0.1, beyond that also. The highest negative spherical aberration lens that we have will cover about 0.27. So at least 0.27 microns can be reduced from the existing. expecting a spherical aberration. And for hyperopic LASIK, exactly opposite happens. So there you can use a spherical IOL or aberration-free lenses. So if you see the available lenses with us, we have Technis one, which is about 0.27 IQ, 7.20, and lenses from Bosch and Lomb can be a zero aberration lenses. Now, coming to optical biometry, so you need to do optical biometry in a obviously post refractive surgery mode. And when you're doing post RK measurements, it's good to do it in the morning because there is a diurnal variation in the corneal curvature with these patients. The flattest curvatures we get in the morning, so that's the best time to record them. And each of your optical biometers will have inbuilt formulas which will cater to the post refractive status. Now, sometimes should we repeat this measurements in another biometry? So biometer. So yes, if you're planning for a toric oil, and this is something which has Dr. Douglas Koch has come up with, where he says that you can consider toric oil if you have a regular bow tie corneal astigmatism within 3 millimeters zone. The difference of equal to or less than 0.75 diopters in the corneal astigmatism magnitude between the two biometers, and a difference of less than or equal to 15 degrees of in the astigmatism meridian between the two biometers. Just to explain you this, you can see this chart. This is a patient who has undergone IOL master and Lenstar. And if you see the axis in the two, the difference in the axis is less than 15. It's around 13 degrees, and magnitude is about 0.54. So this satisfies this criteria of magnitude and the axis, so we can actually go in and put a toric oil in this patient. Now, sometimes you're in a dilemma and you want to do some additional investigations. So I'll give you a case example for that. So this is a patient who he's a 44-year-old, has had a LASIK 15 years back. He has had regression he was treated for -14, now he has -8 and -6, and has been complaining of glare, halos, and starburst for last 4 years, but is also having decrease in vision about 6/12 in the right eye. On slit lamp, we see an early nuclear sclerosis. Now, we don't know whether this nuclear sclerosis is responsible for the symptoms that the patient has, or whether it's the corneal issue, because you can see, if you see the corneal topography here, you can see that there is a slight decentration of the ablation here. So what is the cause of decreased vision? So in this case, you can do an eye trace, which will actually find out the source of aberration and what is the vision quality that the patient is seeing. So here you can see the left eye, all the aberrations are well within the normal range, as a result of which the left eye simulated E that the patient sees is quite clear, whether it's internal, corneal, or the entire eye. That means there is no problem in the left eye. The lens is also okay. But you see the right eye, you can see the internal aberration, the corneal aberrations, they are all high. As a result, the total aberrations in the entire eye are quite high, and you can see the vision quality of the patient. So even if you do a cataract surgery and make this internal aberration to be almost normal, the patient still has a corneal problem to be dealt with, because the patient will not have a very good quality of vision. So in such cases, you would do a corneal treatment first, followed by the cataract surgery. What if the eye trace is not available? So in this scenario, you can do a trial of RGP lenses, and if the vision quality improves, obviously there is a corneal problem and that needs treatment first. And if the vision quality, there is no improvement, you can straight away go in for a cataract surgery. So this is something that you need to keep in mind. And this is the most hot topic, whether to put EDOF lenses or trifocal lenses in post-refractive patients or not. The many such publications are available now, which tells that these lenses do work in post-refractive surgery. However, you need to choose your patients correctly. And patients, these are few guidelines which will help selecting your patients. So very important to know whether the patient had good quality of vision, especially in the night before the onset of cataract, whether the patient has been having good realistic expectation. So because we have to understand this, that whatever formula you choose, the chance of getting a spherical equivalent of less than 0.5 is about 50 to 60%. And you need to avoid in hyperopic LASIK patients, because all these lenses come as negative aspheric lenses. And of course, you need to avoid in comorbid conditions. Another very important point to understand is that if there is a variation of 1 diopter in the corneal power along the meridians within the central 3 millimeter zone, that's also a red flag for these lenses. The higher order aberration value should be below 0.3, and coma and trefoil should be below 0.3. And angle kappa and angle alpha, we all know, should be below 0.6. Having said that, there are many studies, as I told you, which shows that the patients are quite satisfied. Here you can see the satisfaction rate almost 86% after using multifocal lenses in this study. But there are studies which also show that these patients tend to have a higher IOL exchange rate compared to normal corneas. So one has to keep that in mind and do a proper selection. Just to show you an example, this patient was a 43-year-old, had a LASIK done some years back, and now wants a spectacle freedom, and he was looking for an EDF lenses. On his biometry, there was hardly any astigmatism, but when we dissected this patient and did a pentacam, you can see that the pentacam EKR map shows a broad base with multiple peaks. And when we did the analysis, we can see clearly that the higher order aberration is more than 0.3, around 0.5. The coma and trefoils were quite high. And in the meridian, which I was just discussing in the 3 mm zone, the difference is more than one diopter, almost 2 diopters. So this is an irregular cornea. It's best to avoid this thing in EDF lens in these cases. So this is another patient where you can see the higher aberration is just 0.199, and this patient definitely you can consider putting an EDF or a trifocal lens. And you can see the meridian distribution in this, and it is very compact, and there is hardly any difference in the meridian dioptric values. So this patient is a fit candidate for a toric IOL. Now, coming to the calculation, so just to give you an example, this was a lady who has had a PRK surgery done, cataract surgery done in 2021 with a plus 11 diopters thickness 1, and had a post-op hyperopic refraction of +2. So patient then actually was not at all happy and underwent an exchange, and now the refraction is -1. So why did this happen? So where the center where the surgery happened did a conventional calculation, and it turned out to be 11 diopters to a Barrett universal 2 formula. But when we did the calculation using the ACRS calculator, it came out to be close to 13.5. So there was a mismatch. So why does this conventional biometry methods fail? So these methods fail because of these 3 errors. So you have what is called as refractive index error, you have radial error, you have IOL formulation error. Let's understand them one by one. So what is this radial error? So radial error is basically nothing but the fictitious refractive index that we choose while doing the normal IOL power calculation. Now this is fictitious because it was created so that 7.5 millimeter radius of curvature corresponds to 45 diopters of corneal curvature. But important thing is that this refractive index basically works on the assumption that there is a fixed ratio of back to front radius of curvature, also called as Gulf-Strands ratio, which is about 0.82. So this is true in a normal virgin cornea, but in a patient who has undergone refractive surgery, this ratio comes down with the degree of power correction. So that is the reason why this is the error which causes IOL power error, calculation error. So then you have what is called as a radius error. Now what is this radius error? Now we all know that the manual keratometry would measure 3 points at 3 to 0.2 millimeters, but the patient may have a central flattening which this keratometer is not able to pick up. So this can especially happen in patients with RK who have a smaller zone of flattening. So obviously you are measuring a K which is going to be higher than actual K which the patient is using. The third error is a formulation error. So all these formulas like SRKT, Holiday 1, Hoffer Q, Barrett's use K and axial length, this keratometry and axial length, to actually estimate ELP. So if the person has undergone a myopic surgery, he will have a flat K, which would mean that the formulas will assume that the patient has shallow anterior chamber, and it will give you an anterior estimated ELP, which would mean that the formula will recommend a lower power IOL, and there comes a hyperopic surprise. Now this leads to a wrong estimation of ELP, and this will lead to ultimately a refractive surprise in the post-op period. To counteract, Dr. Arambedi had given us this double K Arambedi method, where you use P of K to predict ELP, and you use the present K which the patient has been treated with, predict the IOL power. So this is called as what is called as double K SRKT, Holiday 1 and Hoffer Q. In this, the double K Holiday 1 is actually there in the ACRS calculator, will show you. So somebody who doesn't have any post-op pre-op history, how does one calculate this power? So this can be calculated by this simple equation which we just discussed, that the ratio between back to the front surface is 0.82. So we need the front surface radius of the patient. So you get the front surface ratio by this equation, and then you basically, once you get the front surface equation, you can calculate the K based on the front radius with this equation, and you get the estimated the value. So for example, this is a patient who has had the LASIK, so you get this value of the posterior surface radius here in the pentacam, and this value you can put it in the equation and you can actually get a pre-LASIK K. Now if you don't want to do all this, luckily this gives this report in the holiday report actually gives us this value in the form of estimated pre-refraction K. So this can be inputted in the K in the calculator. Now coming to the IOL formula, so there are close to 30 plus IOL formulas till date that have been described for the calculation for IOL. So how does one know which one is good, which one to use? What is the basis of these formulas? So basically there are two types of formulas. One is conventional formulas, which basically will alter the K, alter the refractive index, or alter the final IOL power that you get. Or you have the newer methods where you don't need too much of alteration, and they depend on newer technologies to get us the result. So coming to the conventional methods, you have three main methods. One is one where you know the pre-op K of the patient and the refraction change the patient has undergone. Second is you don't know the pre-op K, but you know the refractive change. Third is a no history method. So these are the broadly three categories. So in the first category, we expect that since we know everything, it should do very well. So these are the 3-4 methods which are available based on these two values. But unfortunately, this performed the least amongst all the formulas. So this method is no longer used. The second method, where you know the refractive change, that means how much the power has changed, gives quite good result, quite good outcome. So if you know the refractive change, you can use these methods. And if you don't know the refractive change, this third set where there's a no history method also is quite good. And in fact, most of us rely on the no history method only. So for a surgical induced refractive change, this is the formula. And you can do this calculation. It's not very difficult actually. So I'll not go into details because that will eat too much of time, but it's easy to do. And one thing that has happened is over a period of time, Dr. Warren Hill, Dr. Douglas, and Dr. Wang has created what is called as A series post refractive IOL power calculator, which has made life very easy for all of us because it has all the inbuilt formulas. You really don't have to do all the calculations yourself. So when you open this web page, it will ask you what kind of patient you are dealing with. You just have to click and get into this, and this is what you will get. So this is a post LASIK information that you need to put your basic stuff, that what is the name, then what model of lens you will use, what is the eye, what is the target refraction, and pre-LASIK data. If you have to put that refraction, both sphere and cylinder. And if you are putting refraction, if the cylinder value is not there, you have to put 0, otherwise it will not accept. Of course, keratometry values K1 and K2. If these values are not known, you can put the estimated K, which we just discussed. And then you have the post LASIK data, which again through the records you can take in terms of the refraction. And then one of those topography machines which you can use, like Tommy, Nadek, Galilei, or Pentacam, and you can get those values from there, and you need to just input those values. And this is the most important, wherein you input the ultrasound and optical biometry values in the form of K1, K2, which we routinely use. And the important thing is the A constant should be, whether you are using optical or ultrasound, you can use the A constant accordingly. This is for our this is the value of Pentacam. You basically need a value from the power distribution map for LASIK patients. I'll show you how we take it. And for the PRK patients also, you need to use the power distribution map. So this is the power distribution map. In LASIK, essentially, you take the 4 mm zone on this power distribution map, and you need to click the apex. So this zone should be centered at the apex, and you need to take the true net power, a km value for this patient. And for RK, you need to just click pupil, and you need to take the sagittal curvature km value, that is the mean value for a 4 mm zone centered at pupil. So this has to be clearly understood. The LASIK is centered at apex and RK is centered at pupil. And this is how you take you get the value of km from the chart. So once you have done the input, these are the data. These are the formulas that you get. These formulas are available on the web page, and these are the details of the formula. So in some formulas, you use a double K holiday IOL formula. Some formulas are direct. Some formulas like basket adjusts the final IOL power as shown in this table. I don't think so. We need to remember this table because everything is there in the website page. Importantly, if you want to do toric calculation, you can do with the Barrett toric calculator, the Barrett TrueK toric calculator. Now remember, this is a different than the Barrett toric calculator. So this is available on ACRS website. You can do the same input. You need to just click the history, whether it's a myopic, LASIK, or RK. So post RK, this is what you get in terms of measurements. And in post RK, you get one additional formula called as IOL master or lens star formula, which is nothing but a double K modified IOL formula, and it uses a pre-op K of 43.86. So it doesn't estimate. You basically use a default 43.86 and a post-op K from the IOL master or a lens star thing.
सागर तुम्हारे डिनर में चना का चिकपी स्प्राउट है और थोड़ा दाल राइस भी है नहीं खाओगे लेकिन तो बहुत ज़्यादा मात्रा नहीं है इसीलिए राइस ना लो हाँ अच्छा सब्जी करके फ्रिज में और कोई सब्जी नहीं है ना
The newer methods include total keratometry values from IOL master, ray tracing technology from Oculinks. Then you have intraoperative aberrometry and machine learning algorithms. So total keratometry, as we
करेले में खटाई लाल मिर्च सब डाली हो तो आम काट ली हो आम
we all know is a combination of anterior and posterior keratometry values. This is seen in IOL master 7 and and it is called as TK. So if you click TK, you will get all the TK outcomes, and if you click K, you will get values with K. So and of late, the publications have shown that that the Barrett TrueK with TK and EVO TK and Haggis TK have shown to be quite showing good results in comparison to Barrett TrueK. This is the EVO formula, which is also a good formula. You can actually access it online through this link, and here also you can put all the parameters. This is Hoffer QST, wherein also you can do TK version of Hoffer Q and get the result. Machine learning algorithms, we all know the biometric normal biometric calculations are becoming refiner with this the machine learning formulas or AI based formulas. In this connection, the Pearl DGS is the only IOL formula where it leverages both the conventional thick lens equation and the machine learning algorithms, and machine learning empowers this formula to continuously adopt and improve more data as more and more data is becoming available. So this formula is going to definitely become better with time because it keeps improving as more data is feeded in. Now this and now coming to RK patients, what is specific about RK? So patients can have 4 to 32 cuts on the cornea depending on how it has been planned. But the important thing is that you can have smaller optical zones where there is a higher chance of radius error. This has to be kept in mind. And as discussed earlier, that early morning readings are better, and you need to do the calculations based on that. These patients do tend to have higher irregular astigmatism and higher chance of post-op hyperopia. So there is a recommendation of keeping these patients myopic depending on the number of cuts the patient has undergone. So in generally, we keep around -1 to 1.5, but patients who have almost 32 cut RK, there is a recommendation that you need to keep almost more than -2 as a post-op refractive target. IOL for
नहीं खाते ऐसी इसको भी बिस्किट देनी होगी वो बिस्किट के बिना नहीं खाते नहीं कड़क है तो इतना कड़क नहीं खाते
RK, which formula? So probably right now in the current thing, Barrett TrueK and the ACRS Mac maximum IOL power that you get from that tabulation you can use. Now, RK is also peculiar that sometimes you get values below 30 diopters because they lead to extreme flattening of the corneal curvature. Now, if you use ACRS calculator, you don't have an option of going below 30. So one simple thing that you can do is you can measure, start inputting K1s from 30, 31, 32, 33, and then you tabulate the IOL power that you get with 33, 32, 31, and 30, and the power that you get, you find out what was the factor by which the power is increasing. Now, so here in this you can see there is a 1.3 factor. Now we want a 27 and 28, so that is almost 3 diopters less than this. So 1.3 into 3, and you add that value to 21.86 and you get 25.25. This is a simple thing that one can use in patients who have extreme flattened corneas. So let's see some practical examples. This was a 56-year-old patient who has had a PRK 20 years back, and his refraction change was around -9. So from -9, the patient became 0. So if you do a conventional biometry, you are getting about 19.5. But when you do an inbuilt Camlin-Kalossi formula, you get about 21.5. Then there is a Shama's formula inbuilt in this. That also gives you 21.5. And when you run ACRS calculator, you can see how these values are so close that you just need to use the average of all these, which comes around 21.5. And what was the result? The patient was about 6/9 unaided, and the spherical equivalent was 0.15. So when you have formulas giving such close values, you are definitely going to hit the target very nicely. Now, this is another patient who has had a good central flattening, not decentered, higher order operations are within normal limits. And then Barrett True K with TK is giving me 19.5 Technis 1. Now, I ran the same thing with the EVO TK and then with the Hoffer Q TK. And what is the result? That Barrett True K is, for a 0.5 is giving me 19.5, and EVO and Hoffer Q is giving me 20. So we implanted 19.5 in this patient, and this was the outcome. Spherical equivalent was 0.37, which is kind of median of these two. So again, an fairly accurate result that you get. This is an example of a Pearl DGS versus Barrett True K. This patient, we had to use 7 diopters in the patient, and Barrett was giving plus 0.14, and the Pearl DGS was giving minus 0.7 as the expected spherical equivalent. And what did we get? We get a spherical equivalent of 0.35. Again, very close. So this is something which we are happy about. So the next comes another interesting case. This is an RK patient who was having high cylinder, but her best corrected visual acuity was quite good. But if you see the ablation pattern, you can see a slight decentration in both the eyes. But because the BCAVA was good, and we did biometry in 2 sources, and we can see that in the right eye, the difference in the axis was 18, and the magnitude was 5.4, and in the left eye, it was difference was 2, and the magnitude was 9.7, which was kind of close to what Dr. Douglas Koch had given the recommendation. And we went ahead with the toric IOL in both these patients, and the implanted axis was as per the plan. The patient had a fantastic outcome. Patient was plano in both the eyes, 6/9 in one eye and 6/12 parts in the other eye. So this patient was doing well. So coming to my last case, this is a very short video which basically tells us as to how these RK patients can be very challenging to operate. So this is a 50-year-old gentleman who had an RK 25 years back. He was one-eyed because other eye had an RD, and this eye which needed surgery was hand movements. This was the slit lamp examination of this patient. Was a 20 cut RK, grade 3 cataract with posterior subcapsular cataract. A lot of times RK, you will see this central opacification or scar formation over a period of time. So this is a challenging case. So what was the biometry of this patient? So this patient, we did a scan.
सब्जी भुनी हुई है ना एक पान में, इसको लेके दलिया बैठा दो,
biometry, contact biometry. The axial length was close to 35 millimeters. We did the pentacam values. We inputted in the ACRS calculator and the biometric values, and we got the IOL power as minus 5 to minus 7. So we took the highest maximum value of minus 5. So we chose a minus 5 sensor multipiece, and when I'll just show you the video, but before starting the video, the intraoperative precaution that one has to take is that these cases beyond 12 cuts, it's a good idea to use a scleral incision. Always stain the anterior capsule because the visibility becomes an issue. And because now we can adjust the IOP with the current generation machines, we keep the parameters as low as possible. And of course, at the end of the surgery, you have to make sure that there is no RK incision leak. So I'll think we'll put on the video. So here you can see that I am entering in between the incision, and you can see that there is a staining of the anterior capsule. And the rexis was the difficult part, because getting the rexis was difficult, but somehow the capsule was stained and we were able to complete the rexis. So here we are doing a scleral incision, because any incision on the cornea, we would have actually hit the RK incisions and would have opened up. So then the standard steps are going on, and of course here in the sculpting was not possible. So with the help of a direct chop, just feeding the nucleus, we went ahead and did a horizontal chop, and luckily we were able to divide the nucleus, and subsequently the steps were done in a very controlled manner, making sure that no undue pressure is given on the cornea, because we were anticipating that 1 or 2 incisions will open up eventually, because it was a little prolonged surgery and it's a little difficult surgery. So here we are continuing, and of course here the first incision actually opened up, and you just need to do an interrupted suture in this scenario. This patient also, there was a little bit of bag instability, so we went ahead and put an CTR, and this is that minus 5 diopter multipiece lens being implanted. So as we can see, there's another incision which is opened up. This was also being sutured. The third incision opened up, and eventually everything's kind of settled as the surgery went on well. Post-operatively, patient did get ambulatory vision around 2/60, and it was a successful outcome. So in RK patients, we have to remember that you may have hyperopia initially, and the refraction stability may take up to 3 months. Sometimes even it can go beyond that, because these incisions swell up in the immediate post-op. So I would end my presentation by saying that post-op refractive cataract surgery definitely needs more detailed evaluation than your standard cataract surgery. The methods of IOL power calculation are way, way better than what they were about 5 years or 7 years back. And the predictability and ability to achieve plus and minus 0.5 now is almost around 50 to 60%. And slowly we are going towards 70, 80% also, if you combine multiple approaches, multiple formulas, and then choose an IOL based on the consensus. And of course, the choice of IOL, as we discussed, would depend on multiple things. It should not be like one lens for everybody. And finally, the RK patients are always challenged. So always plan your RK patients carefully. I thank you for the attention. I think I finished with this. And of course, this is a procedure which this is a talk which has a lot of calculations, a lot of things. anytime you have queries, anything you would like me to clarify further, and which we are not able to do it here in the Q&A question, we can always mail me. Thank you.
Thank you very much, sir. It was such an extensive presentation and so much of information. But I like the most the initial statement you have made, that you like it or not, you are going to get this kind of patients today or tomorrow. So that's a statement, really, sir. Anyways, we have a question lying in the Q&A box. By the time Dr. Sagar address this question, I request all of you to put your questions in the Q&A box. We will address soon. So the first question from Dr. Harsh is, can I calculate IOL power in post-LASIK patients if I do not have IOL master and topography machine?
Yes, you can do that. You can input the K1, K2 from your automated keratometry values, and you can put the axial length from your A scan. Okay, so these two things you should do, but the most important thing that you need to do is you need to put the A constant, which was giving good outcomes for you with the method with which you are using. Okay, so your A constant would be your A constant, not the optical biometry A constant. So this definitely can be done. One thing to understand is that if you are planning for a premium IOL without doing topography and optical biometry, we will not recommend. But if you are going to do a standard lenses, like a standard aspheric lens in a myopic LASIK, you can very well go ahead with the normal calculations. There's no problem. Absolutely.
Sir, thank you very much. I have a question related to this. Your A constant, what do you mean by your A constant, or the provided by company, not the provided by company?
So people who are very experienced cataract surgeons and who are doing immersion A scan and contact A scan, what they do is, because they've been using that lenses for such a long time, they can actually personalize their A constant. So a company recommended A constant is a 118.4, but a personalized A constant is giving them a good result at 118.3. So my point is that you need not change the A constant based on if you're inputting data in the ACRS calculator. You use your same data in ACRS calculator and get the outcome from there.
Got it, sir. So next question from Dr. Priti is, how you update yourself with innovative formulas?
Yeah, so the best thing is that that every 2 to 3 years you will get 1 or 2 publications by eminent surgeons, which will basically enlighten you about the value of these formulas. For example, there was a paper by Dr. Douglas Koch in 2022, which speaks about how to handle post-refractive patients in terms of IOL power calculation. So you don't have to study each and every paper. You can just study these kind of papers which are published by eminent people who have done a lot of work on biometry. Because what my assessment goes now is that in the long run, most of the formulas will phase out. You will have like Barrett True K formula, Barrett True K TK formula, and the machine learning formulas. Because machine learning formula in a post-refractive surgery scenario will definitely something that will become kind of norm. And that's what we are seeing also now. When we are using Pearl DGS, we are realizing that definitely it's a formula that will stand strong for long term.
So, sir, the next question is very obvious. Again, it is related to formula. What is your choice of formula from Dr. Jain?
So I till date I was for me it was Barrett True K no history method. That was the main go-to formula for me. But since I have now access to IOL Master 700 Pentacam, so what I do routinely is I make a table and I get the values as I showed you in one of the examples, and I do at least 3 or 4 formula calculations and find out what is the range that they are telling me. And based on the consensus, for one point I wrote the consensus amongst the best formulas that you have is what you would use. So right now for me, those top formulas are Barrett True K no history, Barrett True K TK, EVO TK, and Pearl DGS. So these are the three, four formulas that I rely on. And the data
Got it.
also is strong, because if you see in the newer papers, they are showing the accuracy within plus point to plus minus plus or minus 0.5, almost close to 75%. If the cornea is good, that means if the corneal ablation pattern is good, irregularity is not there in the cornea, which I showed you through the pentagram map, EKR map, your predictability increases manyfold. The problem comes when you have irregular corneas, or when you have pockets where there is a spike in the the EKR values. So that's where you will get surprised in spite of the best formula. So cornea has to be good for you to get a good outcome.
Got it, sir. So next question from Dr. Jain is, in case of post PRK, how to calculate K reading IL calculation? I guess K reading is the question. How to calculate those?
So so PRK or LASIK, the approach is the same. And what you are using, what you are going to input in the ACRS calculator, let's be very clear. There are three parts of ACRS calculator which I showed you. The first part is, if you have a topography excess, you can put one of the values from the topography, either Pentacam or ISIS or NIDAC. ACRS gives you that option to put that. If you don't have any access to topography, you can directly put in your biometric K1, K2. So you really don't have to go on the topography machine to hunt which K I should use. Previously, when these things were not there, we would actually go on the topography screen and find out the flattest K on the screen and try to use that for the calculation. So that now no longer is needed, because these formulas have taken care of all those things. You just have to use the biometric K, either from the IL master or from your auto K, or whatever method you are doing, and you can just input that in the ACRS calculation. Okay.
Okay, sir. So next question from Dr. Preeti is, RK leaks you manage with suture or the glue?
So most of the RK leaks happen at the junction of the limbus. So usually suturing is more than enough. One or two sutures on those sites are more than enough, and they seal quite fast actually. And you just need to keep a patch for 24 hours. The next day, when you open the patch, you can just do see whether there is any leak. But till now, whatever cases I have handled, and leaks actually do happen, but it's not that it's very common. But they seal very well with a single interrupted suture. There are reports where people have used bursting sutures also, because if there is multiple leaks and multiple, people have used a single suture going all across and creating a bursting kind of suture. So that is also described, but it's not, most of the cases it's not that extensive. The key is that you keep the parameters very low. You don't allow the IOP to go very high, because that will ensure that there is not too much of pressure on the incision. So then the chances of leak is anyway reduced.
Yes, sir. I was about to ask the same question. Yes, we have a significant role of intraoperative pressure or bottle height. If you reduce that pressure, and that the chances of leakage reduces further. Okay. So, sir, we have next question from Dr. Meenakshi. Is if refractive surprise, how to manage?
So the refractive surprises, obviously, it depends on how much is the degree of refractive surprise. So what happens is, I have seen refractive surprise up to +8. Patient has had an RK cataract done elsewhere, came to me with a surprise of +8. So obvious choice in these cases would be an IOL exchange. And that patient came to me in about 3 to 4 months. It was post RK. So we went in and did an IOL exchange, because long-term IOL exchange is always a good idea. The other patient which I showed you that had a +2 refractive surprise, the place where they had undergone the primary surgery, the surgeon there himself actually did a IOL exchange for that patient. So IOL exchange would be number one if you are dealing it with in a very early stage. But if you are dealing at a very late stage, then either you can do a surface procedure if the corneal thickness permits, or some people will do a piggy bank, or possibly then the other thing that you can do is you can balance the other eye surgery and target a power such that it is within 3 diopters of anisometropia if the patient doesn't want treatment in that eye.
Yes. So, sir, it means that a plus power is more vulnerable than a minus power. Still,
Yeah,
patient
any
can
day.
cope up with a
Yeah, any day.
So,
So hyperopic residual error is very, very problematic. It's very even a +2, +3 patients are extremely unhappy. Extremely unhappy. That's the reason why RK you would want to keep a little on the myopic side itself. No, no issues.
sir, then we have our next question, which is very much relevant. How to calculate new IL power in cases of IL exchange in a post LASIK case
So
or
I
a
think
post
you,
RK?
I think you have that calculation in Barrett's refractive suit in IL master. There is a formula there where you can actually decide what lens one can implant. Uh, I don't have it off record right now, but there is a formula which you can actually decide what lens you need to implant. Other way is that when you do you can do an aphakic refraction after removing the lens, or the best thing is how to do it is, as I told you, you can do a back calculation. So you have all the parameters and do a back calculation and see that what has gone wrong.
So, yeah, so sir, first of all, that Barrett RX formula will not work as because that is not meant for post
Correct,
LASIK cases. Uh,
correct.
okay, so that's a very important point that we shouldn't go for Barrett RX like in post LASIK cases. We have to look for other formulas.
Best is that you do a repeat post LASIK IL power calculation with the current formulas and try to find out what went wrong actually. Why did it happen? So we as I showed you in my example, we redid the whole calculation for that patient where there was a surprise, and we found out that the patient was given an undercorrected IOL because the calculation was done conventionally rather than doing it as a post PRK IOL power calculation.
So, sir, if we
So
answer Doctor, yeah, sorry.
uh, yeah, go ahead.
So, Dr. Harsh question that a repeat biometry and then put it in
Correct,
Barrett
correct,
true K
correct, correct,
formula,
correct,
then probably still it can be
correct.
closer to any calculation.
Yes. I'll tell you one more thing. When you do a repeat power calculation in these pseudophakic eyes, remember this is a pseudophakic eye. Two things will differ
record कर
now.
लेना.
What will differ is the AC depth. Okay, AC depth will become deeper. Number one. Number two, the lens thickness. The lens thickness, the standard lens, the cataractous lens will be about 4.5 millimeters, whereas this lens will be much thinner. So these two inputs, when you do the calculation, should be changed. So you can take a clue from the other eye, or you just put a standard value, because otherwise the current generation formulas are thick lens formulas, which basically involves both the thickness of the eye, the lens also, the anterior and posterior lens curvature, and everything is included. So one thing you have to remember is when you are inputting these values, these two things have to be modified, because otherwise you will get a different outcome.
ज़्यादा था क्या आज पेशेंट्स
कम था.
दुखी हुए इसलिए कल कितने बजे जाओगे बच्चे
6 के साथ.
It in pseudophakic mode. What
Yeah,
about that?
you can do it. Yeah, pseudophakic mode also it will
मुझे भी भेज देना
it will give an issue. We have had done this, but what we have done is we have changed the anterior
Sir,
chamber
if-
depth.
if we
Because
calculate-
right now, yeah,
Put it in pseudophakic mode. Should it be enough?
yes, but
Hello?
hello, yeah, you can hear me.
Sir?
Yeah, you can hear me. Hello, hello. Hello.
So, Sir, the last. Yeah.
Your voice is breaking. Your voice is breaking. I can't
Sorry.
hear you. Yeah.
Please go ahead. Yes, sir. We can hear you, sir. Loud and clear.
Yeah. I could not hear your question, last question.
Sir, we'll. There is little bit of delay.
Yeah.
The last question is in case of RK, phaco or SICs, what is your preferred method?
I would do a phaco
So
only.
the question number 10, in case of post RK, phaco or SICs, which is phaco or SICs?
I think I would
Which one
do a
is safer?
phaco. Yeah, I would do a phaco because it gives me a little better anterior chamber control compared to an SICS. Yeah, because SICS would involve a little bit of more anterior chamber manipulation to get the nucleus out. So in that scenario, there will
And the
be a
last
chance
question,
of
what is the main reason for IOL surprises?
IOL
And
surprises.
the next
The main
question is,
reason
what is the main?
one of the main reason for IOL surprise is corneal measurements.
मेरे यहाँ देखो पता नहीं क्या हो गया इतना बड़ा पिंपल
Corneal measurement.
लेकिन किसी भी साइज का हो टेंडरनेस थी माथे पे और अब ये
IOL surprises
Boys,
mainly
boys,
happen
boys.
because of
यहाँ
corneal
पे
measurements,
जहाँ
number one,
चश्मा पहनना
and
है,
Sir,
number two, not
क्या करूँ मैं
Question
Commentary.
is from
Hello. Yeah, I didn't get your question. I think there is some connectivity issue. I'm so sorry. I can't hear the
जहाँ
question.
बताओ स्विमिंग कैप को ही कैसे पहनना है
आज आ गया था तुम उसमें कितना ग्राउंड मार दिया हैं?
मैंने उसको बताया
क्या
टीचर को कि मेरे पति 40 राउंड करते हैं तो वो भी शौक थी
क्यों वो तो खुद ही करती होगी ना
कोई भी करता 40 मतलब 20 इधर 20
हाँ।
इधर
अब बड़े पुल में तो 20
English.
एक
Yeah,
किलोमीटर
I
होता
don't
है
know what is the problem. Is it at my level there is a
तो
problem
25
or
मिनट
what
हो
is
गया
the
25
what is the
मिनट
issue? I can't hear.
मैं तो मुंह बाहर
हाँ।
निकालते समय पानी भर जाता है
Sir,
होने लगता है
Yeah.
मैं उसमें
You
डर
already
जाती हूँ, परेशान
Explained the 3 reasons why this
Yeah.
आज सुबह टीचर आई थी वहाँ की एक मैं सोच रही थी कि सुबह एक राउंड मार के
The last-
फिर आलस में हो गई
question.
तुम तो आज बहुत
It's
late आए,
completely
8:15
breaking.
आए।
Why it has happened? I don't know. I'm so sorry.
प्रतिमा को पूरा नीचे तक लेके गई मैं कार तक
Can I see the question somewhere? I can't.
कितनी देर आज की है जिम और कितनी देर हुआ
जिम 1 घंटा 15 मिनट और वो 30 मिनट्स 580 मीटर 550 मीटर 30 राउंड वो तो कोई भी कर लेता है बहुत लोग करते हैं 40 राउंड कुछ नहीं
सिंगी जी करते हैं
वो तो आधे स्विमिंग पूल ही करता है
हैं
वो